All right, welcome everybody to our National Journal Club, and I hope everyone had a nice weekend. Today we'll be discussing carbon monoxide poisoning, the pathophysiology, and some clinical studies. So just as a reminder, we're being recorded, and also as a participant, you come in muted, and if you would like to make a comment, you can raise your hand, and I'll call on you. But I'll try to unmute everybody during the discussion breaks. Our first presenter is Dan Ristiniak.
Okay, thanks. I'm going to talk a little bit about the article from Steve Thom in the PNAS journal, but I think less so as a specific journal review and more so as an introduction into the topic of delayed neurologic sequelae. And the reason is that I remember vividly being a fellow, and like a lot of fellowships, we had hyperbaric chamber. And I can remember getting the call at 2 in the morning that a carbon monoxide poison patient was in the emergency department. That was the most dreaded and hated call of my whole fellowship, because that meant that I would probably be stuck for 3 hours sitting by a plastic tube with somebody in there complaining that their ears hurt. And the thing that was always difficult for me as a fellow, and I don't know if others have felt this, is that I would go see this patient, and they would be awake, alert, and talking to me, and they would have had a reasonable carbon monoxide exposure, maybe have had lost consciousness, but by the time they came to my hospital, or by the time that I got there, they were awake, alert, and essentially normal. And I knew that background on hyperbarics as being a potential treatment for CO, particularly in the setting of changing the half-life carbon monoxide had in the serum from 3 hours down to about 20 minutes. And so I kind of viewed this initially as gas dialysis, that, you know, the sick patient who was hypotensive and intubated, I saw a benefit for hyperbarics because it would be essentially dialyzing, not really, but it would be removing this carbon monoxide and allowing them to return to a normal homeostatic state. A lot of this changed when I took care of this patient. And this is a patient I took care of in her MRI who had a carbon monoxide poisoning, and then 10 days later came back to our attention after she developed really what sounded initially like a psychotic break with altered mental status and confusion and really inappropriate behavior. Eventually, the family had to physically remove her from the bathtub. She was in it naked and eating soap. And when she came back, we ended up getting CT and then this MRI, which showed, as you can probably appreciate, fairly significant white matter changes in the frontal lobes, and there were multiple scans that showed this. And this was, of course, everyone knows, a radiologic manifestation of what we're talking about today, and that's delayed neurologic sequelae. And so the first time I really saw this in my face, it was impressive how disabling this condition was for this person, and what a long rehabilitative process she had to undergo before she could return to somewhat meaningful existence. And so then I started thinking, well, this is a horrible disorder, but does HBO really work for it? And the problem I always struggled with as a basic science researcher is if I can't put a mechanism to it, I sometimes struggle with potential therapies. And I followed Steve Thom's work for a long time, and he had done a lot of really nice and elegant studies in looking at the way carbon monoxide causes injury. And in some ways, I think this PNAS article really ultimately was the one that opened up my eyes to understanding why HBO might have a benefit. So you can go next slide, Louise. This is the article that I had us to look at, but not to go into specific unless folks want to, but the next slide. But Thom's work really showed pretty convincingly in this article that this was an immune-mediated phenomenon. And the way he did so, and kind of the money graph, if you want to talk about that in their paper, was figure 6, which looks at the maze maneuvering scores these animals had. And just to kind of orient folks who probably don't do animal research, but what he looked at was something called an entry to repeat score. And essentially, this is what's called a radial arm maze. And the interesting design of this is that you put the animal in the center, and the animal has 8 choices it can go to. And 4 of those choices in this example, but I think maybe in theirs all of them have a food treat. It turns out that actually what they always get is a Fruit Loop. Rats love Fruit Loops, as do children, which probably shows there's a strong link between their cortexes. But the interesting thing is that an animal is in the center, it'll go down one arm, get its treat, and then it has to return to the center again. And then the process of memory, cognition, executive function go into order. It has to, first of all, recognize it just went down this arm and then choose other arms. And in a rat that is well trained, the number of times the number of times it goes down an arm only once before it repeats goes up. So if the rat had a perfect memory and perfect cognition, it would only go down one arm one time, and then eventually, after it had gone down all 8 arms, would potentially then go down an arm it had been down before, and that would be a repeat. So to some extent, you would think that 8 would be a perfect score since there's 8 arms here, that it would go down each arm only once before it started to repeat. If it has problems with memory, if it has problems with executive function and cognition, it may not remember what arm it went down to, and so it might have gone down one arm, got a Fruit Loop treat, and then go back to the center and immediately go back down that arm again because it can't remember. And that would be a really low score, like an entry to repeat score of essentially 1. And these animals are trained and they go over time. And what happens is over time the animals get, if you want to use the word, smarter as they keep getting conditioned to this. And so their number of times before they repeat an arm continues to steadily go up. And you can see that, you can go to the next slide, Louise. You can see that nicely here in the control animals, which is the kind of the steeper sloping curve. These are control animals and animals that we'll talk about in a minute that were gavaged with myelin basic protein. And that's a normal group. You expect them to continue to go up every day as you continue to test them. But if you look at the carbon monoxide exposed group, and that is the kind of flatter line, you see that those animals really don't improve that much with repeat testing. And this has been a model, at least, of delayed neurologic sequelae in rats. Now, you could argue whether this really applies or not, but keep in mind that a significant CO exposure, and Tom goes into nice detail, and he's done lots of studies using his protocol, alters these animals' ability to increase their performance in this test. So something's altered in their brain. The thing that makes this study so fascinating is this was the first one that really suggested that process that is affecting these animals is immunologic. And if you go to the next slide, Louise, what his work, if you look at it from its entirety, suggests is that you get an exposure to carbon monoxide, it binds to hemoglobin, that causes anoxia. It also binds to cytochromes, which contributes to that anoxia. So you get local tissue anoxia. If that gets systemic enough, you will eventually develop hypotension. And when that occurs, you lose consciousness. That turns out to be a good marker. Then, if you're removed from the environment, you get reperfusion, and you get fresh blood that goes there. Well, during all this process, all these local hydroxyl radicals and all these free radicals are formed, and those things then start being perfused, and then you get what's called lipid peroxidation. Essentially, cell membranes, which are fat, start to break down, and you get lots of alterations to proteins that are sitting in those membranes. And this study really focused on one of those mainly, and that was myelin basic protein. And that makes sense if you understand that, like our patient's MRI, that this is really a white matter disorder. And myelin, being on those white matter tracks, is one of the major proteins. And so it turns out that in his model, myelin basic protein is altered, and its alteration makes it now immunogenic. And he's able to show that by showing that lymphocytes from the animal's lymph nodes will respond when given myelin basic protein by replicating. Microglia, which are resident macrophages in the brain, are also activated. So this created a plausible model for why there's a delay, that it takes time for this alteration to occur. You have to get activation, and then it becomes essentially an autoimmune disorder like multiple sclerosis and other disorders where your white cells are being recruited to this area, they're attacking it, and then you're getting some injury. The thing about this study that was so fascinating, if you could go back to the previous slide, Louise, is Thom used a technique that's been known for a long time to really make a strong argument that this is immunologic. Not only showing lots of immunohistochemistry staining that, yeah, there's activation of white cells, and yeah, there's markers of all this stuff. But he used something that's been known for a while, and that is if you feed animals a protein, they will view that protein as being normal, and they won't attack it. And so if he fed these animals myelin basic protein for several days, I don't remember the number, but several days before he then poisoned them, they essentially would not develop immune response to an altered myelin basic protein. And that's what you can see in this graph. If you look at the black triangles, those are animals that were fed myelin basic protein before the CO exposure, and they're essentially the same as control animals. And I thought this was really a pretty strong link that if you were able to, if you could predict, obviously, to predict what the immunologic or immunogenic protein was, made those animals senescent against it, that you could then prevent their development of this autoimmune phenomenon. So how does this link to HBO? We didn't go over this article, and maybe that's my fault. Maybe we should have really sent it. But if you look at the next article he publishes in his track record, which is in, I think, pharmacology, I can't remember which it is, but we can send it out. He also looks at hyperbarics as a potential treatment. And if you go way back to some of Tham's earlier work, he's able to show pretty convincingly that one thing HBO does, besides popping your eardrums, making your fellows really annoyed at 3 in the morning, and making people claustrophobic, is it inhibits lymphocytes and it inhibits white cell migration. And so now you have a plausible link for why hyperbarics might at least, in theory, prevent or reverse or treat delayed neurologic sequelae, and that's essentially serving as a way to suppress immune response. Now, I think the exciting part of this paper is not what it also meant in terms of HBO, which is what we're talking about today, but also what it might mean for delayed neurologic sequelae in terms of other potential treatments. And I think there's a whole avenue of things that have not been explored, like pharmacologic agents that are known to alter immune response and lymphocyte proliferation and microglia activation. And there's a whole host of those different agents out there pharmacologically, which if in the end you could call me at 3 in the morning and say, I've given this patient this medicine, I'm a lot more happy about coming to take care of them than sticking them in an HBO chamber. And if the benefits are the same, the patient is going to be much happier as well, because all those of us who have dosed patients probably know that outside of Michael Jackson, most of them don't love it. So that's really all I wanted to do in reviewing this Thom article. I'm happy to talk a little bit more about it if anyone has specific questions, but I really thought that this was a great opportunity to introduce why HBO might have some benefit in treating delayed neurologic sequelae.
Okay, thank you, Dan. I will now unmute so that we can discuss this article.
Yeah, hi, this is Paul. I had a question for Dan about this article, which is the amount of carbon monoxide these rats were exposed to was quite high, and you know, as the methodology suggests, they were breathing 1,000 parts per million for 40 minutes and 3,000 parts per million for up to 20 minutes, and then they lost consciousness. Does one need to have such a intense exposure, and does one need to lose consciousness in order to develop delayed neurological sequelae, or can lower levels where there's no loss of consciousness but perhaps severe headache also lead to delayed neurological sequelae?
Yeah, that's a great question, Paul. The short answer is I don't know. You know, the one thing about animal models is you need to create something that's going to reproducibly cause an effect. And what we know in humans is that the variability of presentations and the risk factors for delayed neurologic sequelae suggest that it's not as simple as this. You know, the original articles out of Korea pointed at, you know, age being a big risk factor. People have extrapolated loss of consciousness. Weaver studies suggested that maybe cerebellar deficits. I think anytime you involve a human here, you've got so many potential variables, you know, underlying status of their general well-being and health, what their circulation is, whether they've got cardiovascular disease. that it's probably impossible to say if there's conditions in which some person would, for instance, develop delayed neurologic sequelae or not. We know from a lot of other conditions that delayed neurologic sequelae really looks like and probably is the same as any post-anoxic leukoencephalopathy. And there's a lot of examples of things outside of carbon monoxide like drowning and hypoglycemia and opioid overdose that cause a very similar phenomenon. And so what probably has to occur based on, if we assume the pathophysiology of all these things are the same, is that you have to develop significant ischemia followed by reperfusion. And whether or not you have to lose consciousness as that, I don't know. Certainly having a low blood pressure combined with anoxia is a good way to get some global ischemia. And so it might just be that loss of consciousness is a nice marker that they had enough of an exposure to do this. But whether or not it has to be there, I honestly don't know. But it is a good question. And it's the hard part about this from a treatment standpoint is that we're probably going to, no matter what we figure out, be stuck with over-treating everybody to prevent this potentially devastating problem.
Yeah, because this also comes up with lower dose exposures, perhaps multiple hit exposures in a household where the furnace is intermittently not working for a while, or even some sort of chronic exposure over a period of days or weeks where there's multiple hits of CO but no loss of consciousness, perhaps no hypotension, and then the potential for sequelae, or at least someone claiming that there's sequelae.
Yeah, I think legally we've all been asked to review those cases.
Do you have any pearls about that?
I say no when I'm asked to review those cases. Now, again, it's the difficult part as a scientist in all these cases is that the answer is I don't know. I can create Tom and others, Gilbert and others have created nice animal models in which you can create deficits, but extrapolating that to humans is really difficult. I think the best you can say is that we know this is something that occurs. The animal data suggests that this is the pathophysiology, and then the rest of it is just the art of medicine, you deciding whether or not you think this person's story is of benefit or not. In the end, you can do what a lot of people do, which is dive these patients. The problem I always had with that is that diving is not a completely benign procedure in and of itself. And we came from a center that really was pretty conservative. We didn't dive a lot of people. You really had to have a significant exposure based on your history. You had to have a loss of consciousness or some ongoing symptomatology for us to consider diving you. But I know there's a lot more liberal, so to speak, centers out there that dive lots of folks. So I don't know the answer, and I'm thinking maybe Louise and Jen are going to give us the answer to that in their next 2 articles. But what is it?
Does anyone else have any comments or discussion about pathophysiology? Okay, we'll move on to our next article presented by Jennifer Achani.
Dan, you're very funny. I wish I had all the answers. It would make it a lot easier. So I'm going to review the inane article. Next slide, please. So it's no controversy. We all know that carbon monoxide is toxic. In addition to the immediate effects with acute CO poisoning, it can also cause the persistent neurologic sequelae, which may or may not resolve, and the more interesting delayed neurologic sequelae, which again can appear after a symptom-free interval. I think what is less clear is what to do with these patients, and that's why we're having this discussion here today. So the article by Inane, they had reviewed several trials and noticed that a lot of these trials had conflicting results, probably because of differences in the populations, the severity of CO poisoning, the differences in the interventions. They chose to compare normal baric oxygen to hyperbaric oxygen in patients that had a transient loss of consciousness. And in comatose patients, they compared normal baric oxygen with 1 HBO session versus 2 HBO sessions. one of the interesting parts about defining their transient loss of consciousness in comatose patients, they later do talk about how they used to define that. Essentially, the attending physician made the distinction. The transient loss of consciousness was defined as malaise or syncope, some impaired period when they were either found or rescued that then resolved prior to being randomized. And then they defined coma as a Glasgow coma score of less than 8. Let's see, this was a prospective randomized unblinded trial. The patients and the treating physicians obviously knew which arm these patients were going to. 385 patients were included in this trial. They essentially included anybody over the age of 15 with acute domestic CO poisoning. The major exclusion criteria were if there was mixed poisoning, if this was a suicide attempt, they did exclude pregnancy, and non-domestic poisoning. The two arms of the trial, again, there was a trial A that they defined the transient loss of consciousness, and again, those people got 6 hours of NBO versus 4 hours of NBO plus 1 session of HBO. And then trial B was the patients that presented with initial coma, who then received either 4 hours of NBO plus 1 session of HBO versus 4 hours of NBO plus 2 sessions of HBO. Next slide, Louise. Their endpoints, they wanted to see how many people had complete recovery at 1 month. A secondary endpoint was also to look at the rates of PNS and DNS in each of the groups. And then another secondary endpoint was the number of patients that were able to resume their previous occupational activity. Follow-up. All the initial vital signs, clinical symptoms, lab data were monitored for each of these patients until discharge. And then at 1 month follow-up, patients were to return to an ICU outpatient clinical setting where an intensive care physician who was qualified in neurology was then asked to perform an exam on each of these patients. Now, that physician was blinded as to what treatment these patients had undergone, but again, the patients were not blinded, and neither were the initial treating physicians who were checking their symptoms at their admission and during their hospitalization. If they could not be followed up by this in this ICU outpatient facility, they were then followed up by their own personal private practitioner. So again, a few definitions. Coma was again defined as Glasgow coma scale less than 8. The transient loss of consciousness was again malaise or syncope. Anyone who did not have an impairment in their consciousness at any point of time was excluded. Complete recovery was defined as no symptom, I'm sorry, I should back up. In addition to being followed up by the physician at 1 month, they also completed a self-questionnaire on their symptoms. I apologize, I should have mentioned that earlier. So this was self-reported, yes, no, about their symptoms. So complete recovery was defined as no symptoms and a normal exam. Moderate sequelae was defined as self-reported symptoms, but a normal exam. And severe sequelae was defined as a neurologically abnormal exam. Next slide. So before we talk about the results, if you look at Table 1, this was the baseline comparison of the randomized patients, which showed that they were pretty evenly matched for the most part. Table 2, and I kind of summarized their endpoints in my table here, but the first arm of the trial, Trial A, where they compared, again, the transient loss of consciousness MBO group versus the MBO plus HBO group. The difference in recovered was essentially the same, as well as the rates of DNS and PNS at 1 month. And only one reported no resumption of former activity. That was trial A. Next slide. For trial B, which was the 1-session HBO versus the 2-session HBO, in addition to the previous 4 hours of NBO before the HBO sessions, there was a statistically significant difference in the rates recovered at 1 month. It was 68% versus 47%. Differences in DNS were similar. The rates in PNS were higher in the 2-session HBO group, in addition to also having more patients not resuming their former activity in the 2-session HBO group. Initially, the trial, using their statistical analysis, they were to have 970 patients needed for the trial, 490 in trial A and 480 in trial B. They did an interim analysis at 300 patients to allow, to check for differences in the treatment protocols and their adverse events and whatnot. They ended up terminating the trial prematurely based on this rate of recovery in the trial B group, since they did show a poor outcome with the 2 HBO sessions. They did terminate this trial. Interestingly, they also comment that when they analyzed trial A, that they found no significant difference and therefore terminated that trial early as well. So because of this, they concluded that the study did not confirm that hyperbaric oxygen improves recovery from a pure CO poisoning standpoint, and in addition, in comatose patients, repeating the hyperbaric oxygen therapy resulted in worsening outcomes.
Thank you, Jen, for that discussion. I will move on to the third article. I'll be discussing the Lindell Weaver article, where he goes into the risk factors for cognitive sequelae and the role of hyperbaric oxygen. So as we know, carbon monoxide poisoning is associated with cognitive sequelae, and hyperbaric is thought to potentially reduce that risk. However, treatment criteria as well as protocols are controversial, and so this study sought to determine which patients are at increased risk of cognitive sequelae. This was a post-hoc analysis of data from their previous 2002 clinical trial, the double-blind randomized trial of the hyperbaric oxygen versus normal baric oxygen. They included their randomized patients, not all of them, but 147 of them, and also eligible but non-randomized patients, so 91 patients that were not included in the original randomized controlled trial, but whom they followed for what they called the long-term study anyhow. The criteria for enrollment were a documented carbon monoxide exposure plus symptoms, and they had a list of symptoms: loss of consciousness, confusion, headaches, fatigue, dizziness, malaise, visual disturbances, nausea, vomiting, cardiac ischemia, and metabolic acidosis. Of those 91 non-randomized patients, these were the reasons why they were not randomized. 30 of them had been greater than 24 hours since the most recent carbon monoxide exposure. Of those 30, 19 did not receive any supplemental oxygen therapy at all. Other patients declined to be enrolled because of inconvenience, cost. There were some chamber issues whereby the patient was unable to tolerate hyperbaric oxygen. Patients were unwilling to participate, there were transport issues regarding participation, unable to consent and did not have a proxy. The referring physician declined, and then in 2 cases it was unknown why the patients that qualified for the study were not randomized. They collected the demographics as well as the circumstances of poisoning, such as was it a suicide attempt, was it a house fire, and that kind of thing. They performed neuropsychometric testing at presentation at 6 weeks, 6 months, and 12 months following poisoning. Cognitive sequelae were considered present at the 6-week mark if they had a single neuropsychometric test subtest score of greater than 2 standard deviations below the mean, or if they had 2 or more scores greater than 1 standard deviation below the mean, or if the patient had a complaint of memory attention difficulties and had 1 score at least 1 standard deviation below the mean. So once you met any of these criteria, you were considered positive for cognitive sequelae. They performed a univariate analysis on patients that did not receive hyperbaric. So they basically lumped the patients that did not receive hyperbaric from the randomized controlled trial with these other 91 patients that did not enroll in the trial to identify whether there were potential risk factors in those that were classified as having cognitive sequelae. They looked at a long list of risk factors to assess for potential significance, including, levels, was it intermittent or continuous exposure, was it a suicide attempt, did they have loss of consciousness, and was it prolonged? They followed that by a multivariate logistic regression to determine if there was an association of any of these risk factors to ultimately being diagnosed with a cognitive sequelae. Then they, following this, did a separate logistic regression on the entire sample to identify risk factor association with cognitive sequelae and whether it varied depending on if you received hyperbarics or not. So here were their results. They found in the hyperbaric oxygen group, so these were all in the randomized controlled trial, 24% versus 42% having 6-week cognitive sequelae, 17% versus 30% having 6-month cognitive sequelae, and 14% versus 18% having 12-month cognitive sequelae. They did also note that the magnitude of cognitive sequelae was the same across all groups. So they found that in the non-hyperbaric group, several items were thought to be associated with cognitive sequelae: age over 36, carbon monoxide exposure of duration of over 24 hours, an intermittent exposure, coming in with initial memory complaints, and interestingly, the level of the loss of consciousness and the carboxyhemoglobin levels were not found to be associated. After the multivariate analysis, they found 2 factors that remained significant, and those were the age of greater than 36 and the prolonged carbon monoxide exposure. In the hyperbaric group, they found that patients they specifically separated out greater than 36 years and found that those patients treated with hyperbarics had a reduced incidence of cognitive sequelae at 6 weeks. They did not find that patients with the greater of 24-hour exposures, i.e. the prolonged exposures, had any difference in 6-week cognitive sequelae compared to those that were not, but they did comment that there were only 5 such patients in that group. So here were their conclusions. They concluded that symptomatic carbon monoxide poisoning patients 36 years and older should receive hyperbaric oxygen regardless of loss of consciousness or initial carboxyhemoglobin level. They then go on to review the subgroup analysis from their randomized trial and end up concluding that our findings support that hyperbaric reduces cognitive sequelae in poison patients that are older or have longer exposures to carbon monoxide. In addition, we agree that hyperbaric is indicated for patients with loss of consciousness or higher carboxyhemoglobin levels. I will unmute the group so that we can have some discussion about these clinical articles. Would anyone like to discuss their philosophy or treatment protocol regarding these new studies that have come out?
Well, this is Paul. I'll ask a question. Thank you for the articles. What is the proposed mechanism that 2 rounds of hyperbarics lead to worst outcome with in the first study that you presented?
What was the proposed mechanism?
Yeah, or what do you think the mechanism might be? Why might that occur?
They didn't really talk about that in the article.
That's right. So you have any idea? Because some of us work in hyperbaric units where most of the folks are getting it for their wounds, of course, and people go through 40 treatments or 60 treatments. They go through many treatments, and I'm not aware of people saying that it's impaired them cognitively because of all those treatments. So I'm wondering, in the CO-exposed patients, why 2 treatments might impair them more than 1 treatment.
I honestly don't know the answer to that question.
Okay.
Yes. If I could interject for one quick second, at least if you believe the pathophysiology, the only real benefit I could see looking at, like Tom's work and others, is that you need to continually suppress the lymphocyte activation, so that the thing that Tom's follow-up work showed is that hyperbarics does not prevent the alterations in myelin-based protein. It only prevented the immune response to that. So that the damage is done before you see the patient, and that if HBO had a role in terms of multiple dives, it might be to, so to speak, if you think about it, like getting another dose or immunosuppressant. Now, that said, you would certainly need human data to support that, and I no way, shape, or form am supporting we dive. We didn't at our center do multiple dives. You got your 1 dive, and that was it. But at least from a theory standpoint, that would be one that you could try to fit for a multiple dive benefit.
I think the way the research has shown us is that there are so many different practice patterns regarding this issue. There are people who have looked at the data and have decided that the weight of the evidence does not support this treatment. And the recent Cochrane collaboration review that just came out came to that conclusion, that the weight of the evidence, which granted this is a very difficult population to study, but that did not support hyperbaric as a standard of care. On the other hand, you have other opinion leaders that have said that hyperbaric oxygen is not only indicated, but it would be unethical to perform further trials because it is the standard of care. So we have this big disparity, within our specialty regarding kind of what to do.
Louise, I think Phoenix has their hand raised too.
Okay, yeah, everyone should be off mute. So
Hi.
Thanks.
Sorry. It's Aaron Skolnick in Phoenix.
Hello.
Yeah, I wanted to comment on the question that was asked earlier about the proposed mechanism for why, could somebody be injured by multiple hyperbaric. Oh. Can you hear me?
Yeah.
Yes.
Okay. I don't know the literature very well, but I know there is some literature from the neurology and neurosurgical literature about this idea of hyperoxia-induced, cerebral perfusion decrement. And what I've seen is mostly studies looking at using hyperoxia as a contrast agent for kind of fancy MRI studies. And the last I saw, there was still some disagreement about whether it causes any clinically significant decrement in cerebral blood flow. So that might be one proposed explanation. But I think this study as a whole has so many methodological problems, both from the definition of coma to the non-blinding of follow-up examinations to the way in which sequelae are defined. And then looking, if I'm not mistaken, at the adjusted effect on recovery rate in trial B, the odds ratio 95% confidence interval crosses 1, even though unadjusted it looks like there's a statistically significant difference. So I'm not sure, adjusting for baseline differences in groups, if you can really say that there is a difference in recovery at all between those two groups.
Yeah, I can chime in a little bit, just as being, Louise and I both participated in a study of hyperbaric in which the data suggested that those who received it after cerebral ischemia were harmed and not benefited. So we have contributed to the negative HBO literature. It is funny, that article gets referenced a lot, even though it was just a pilot study, because it's such a volatile issue in people. You know, the immune benefit by inhibiting the immune response, really, the problem with HBO is just what you pointed out, is that there's also a whole potential harm side of this in hyperoxia and its ability to potentially increase excitatory amino acid release and oxygen-free radicals and all of this. And so that's why when I read that PNAS article years ago, the thing that I was filled with excitement was not that this maybe made a link to why HBO might be a benefit as an immune modulator, but more that if that is true, then there's a lot of pharmacologic agents we've invested time and energy into that probably better inhibit immune response, and maybe that ought to be the focus of our future treatment. I don't know if that answered the question besides me just rambling.
I'm wondering if anybody routinely dives patients purely based on an age of over 36.
Sounds like no.
Yep, sounds like no.
I always wondered, I think the thing that was always interesting for us is, for people who are passionate about this, is if your loved one was CO poisoned, would you dive them?
I feel like we get that question a lot from family members when my approach to these patients is that I kind of explain to them, you've had carbon monoxide poisoning, here are the treatment options, here are the pros and cons, and I do kind of tell them there is a bit of controversy about whether this is beneficial or not, and that kind of, I think there's likely a subgroup that may stand to benefit that we have not yet identified. Until that happens, I kind of let the patient and their family weigh in on whether they would like to have the therapy. And when I do that, I do tell them that it has been suggested that an age over of 36 is a risk factor.
Well, yeah, this is Paul. I mean, my concern at this point is the potential adverse effects of this treatment now that you've been discussing. And in that one paper, you know, two treatments worse than one treatment. You know, is there evidence, and Dan, you may have some pilot data on this, suggesting that, you know, one treatment is worse than no treatment, and that we're actually putting our patients at risk by recommending this treatment?
I don't. And I don't recall off the top of my head. There was some animal data that looked at the time to initiate hyperbaric as a potential factor as to it had to be there within, I think it was 6 hours, and then later than that, actually, it was causing some harm. So outside of that, I don't know a lot, but there is data out there to show that on top of all of the other confounders and all the other difficulty in sorting through this literature, that there might also be a time-dependent factor, which, as we know in the brain, unlike other organs, time for a treatment initiation seems to be the norm.
This is Mike Holland. I just wanted to mention something. Can you hear me?
Yes, yeah. Go ahead.
Yeah, the innate study was, I think, one of the main problems with that is the dose. I mean, he gave 2.0 atmospheres, absolute. And I think we pretty much know that you have to have above 2.8 to actually inhibit beta-2 integrins to actually make an effect to try and reduce the delayed neurological sequelae. So I think that was doomed to failure to show any improvement just because he didn't use the right dose.
I agree. I think there's a lot of flaws in this study, as somebody else from Phoenix pointed out. They couldn't even classify people into the correct groups. If you look at was that the first table, figure 1, there were 6 misclassifications on one side in trial A and 12 in trial B. They excluded 14 because they couldn't determine classification. So I think there are a lot of flaws in this study.
Oh, yeah. There's a lot more, but, yeah, I was just wanting to mention that, but I agree with you.
Yeah, at the end of their study, they talk about needing to do more research into the specifics of the HBO dive as far as timing and, you know, ATAs and whatnot. So they leave it kind of open-ended at the end of their discussion, but I agree with you. There's a lot more questions than answers after this article.
Yeah, and Mike, I think the point you bring up is a great one also, which is that we don't even know the proper dose of this treatment. If you think about most of the drugs that we administer to patients, you've got to go through all the dose trials and all the kind of things. But tox is such a difficult area to research that, you know, people just pick the dose. And you're right in that Tham's work is always 2.8, and he's done that in some human stuff as well with human lymphocytes. But we don't know the dose, we don't know the frequency, we don't know the timing. So there's almost as many questions as to the actual proper protocol as there are to answer.
I think the list of what we don't know with this topic is much, much longer than the list of what we do know.
So this is Paul again. So based on all these unknowns and the conflicting papers, et cetera, what are people's approach to the use of hyperbaric oxygen in these patients? It might be nice for some of the fellowships to discuss what their approach is so we can understand where the variability might be from one site to the next.
I can tell you that at our site, we currently only have hyperbaric oxygen capability during business hours. There is another center fairly far away that does have 24/7 capability, but several hours away. My personal approach is to kind of bring the patients and families into it if the patient is carbon monoxide poisoned but now awake and alert and maybe not that symptomatic, which is, I feel like, the controversial patient.
Are we unmuted?
Yes, everybody's unmuted,
okay.
so feel free to chime in.
This is Phoenix. So just, you know, obviously no one knows what to do, and there's a lot of controversy even within our group, although I think we all agree that we're not totally enthused about diving people. But one thing that you mentioned that, you know, some people want to completely put it in the hands of the patient. So we have some people who will, you know, pretty much let the patient decide. But some others here don't really agree with that approach because if we don't even understand, how are we supposed to ask someone who really has no idea? So, you know, a lot of people are just looking for our recommendations. So we sort of have to decide what we recommend. And we can explain that it's based on very little evidence and they can choose either way, but you sort of have to pick what you recommend, and oftentimes patients will do that. Of course, our recommendations are all over the place, I think, but in general, we will dive people who have some persistent neurologic dysfunction on our exam. Some people will dive anyone with loss of consciousness, but not all of us will. We don't take levels into account. We don't take age into account. And then Aaron had one other comment, too.
Well, and, you know, I'm sure this comes into play for other fellowships, too, but, you know, we live in a state that's largely rural, and we accept transfers from outside hospitals all the time. And one of the things that I think we have decided as a group is that we don't feel like it's the right thing to do to expose patients who are far away to the risk and cost of an aeromedical transport, you know, to come to us and have a therapy that doesn't have a clear and well-proven benefit. And so we won't transfer somebody who perhaps had a brief loss of consciousness but is now completely asymptomatic with the plausible carbon monoxide exposure just to receive hyperbarics at our center.
Hi, Louise, Steve Axe here. Can I talk?
Yes.
Yeah, so, in Chicago, from our perspective, we agree very much with the Phoenix group. We don't have hyperbarics at our center, so we're more involved with interacting with the hyperbaric referral facilities that are elsewhere. So, we stick to standard criteria. We definitely use loss of consciousness. We use pregnancy status as reasons to tell referring hospitals to send it to the hyperbaric centers. And we pretty much, just keep it on these simple criteria to even consider it. We also encourage conversation with the hyperbaric centers, being mindful that we don't have good guidelines at all. Actually, let me pass over to Sean Bryant. He did a recent study just that speaks to the issue of variability.
Yeah, it kind of goes along with what Dan mentioned a little while ago, which I think, for me, just hits the nail on the head about the idea that we have a therapy that we're not even sure is the silver bullet for this poisoning, and now we've got people using all kinds of different protocols, durations, depth of dives, et cetera. And we basically just did a little survey study that got published a few months ago in the Undersea Hyperbaric Medicine Journal, and it was just looking at Midwest centers that would treat CO poison patients with hyperbarics. And we found 30 centers and interviewed them on the phone to find out if they had a protocol. And it was interesting, we found out over these 13 centers, there were 19 different separate treatment protocols. Some used symptoms, some used levels, some used 2 atmospheres, some used 2.5, some went up to 3. And we went into this study thinking that because Weaver does have an article out there, regardless of if you believe it or not, or considering some of the pitfalls in doing such a study, it did conclude that 3 treatments within a 24-hour period was beneficial. We kind of thought that we would get at least, a subset of these centers that would use that, and we found, I think, 2 centers that when they decide to dive someone, that they use the literature to actually support their duration and protocol for treating patients. So they'd put them in an OBS unit, treat them over the course of a day 3 times. So we just found that very interesting, and I just find this very frustrating when, maybe it is part of the treatment, or, I did hyperbarics for 1 year, and maybe I would be in the camp that would, if I had my kids at home passed out and I brought them in and they woke up, sticking them in a chamber, in my opinion, is pretty benign, and I would probably do it hoping to not miss an opportunity to prevent a delayed neurologic sequelae, even though knowing I'm not sure if I'm benefiting them or not.
Sean, I'd give your kids some Solumedrol also now.
No, you're not touching my...
Don, I would love to have a copy of that study.
Sure.
So our protocol here, we do a single dive, and some of us will do a second if the patient is persistently symptomatic. Does anybody else have comments or discussion?
Well, Sean, this is Paul again. Sean mentioned that, he'd spent some time doing HBO, and I've done some of that as well. And, for those of us who've worked in the HBO chambers, it's amazing what gets dived, because obviously most of it's wound healing. People go through, an amazing number of treatments. There's relatively little data to support that, and yet it's happening in a lot of centers, and there's so much variability regionally in terms of hyperbarics. For instance, in some of the major metropolitan areas, there may be only 1 or 2 centers, and while in other places like where I'm at in Dallas, there must be at least 30 hospitals with hyperbaric chambers, and they're always filled. And so I guess, the question is, since it's such a routine treatment for some, is, again, what's what's the downside? Why are we so, cautious here? And I just throw that out, as a thought question.
I totally agree with Michelle that it would be great if we as a group could come up with guidelines that everybody agrees with. That would be wonderful. That would simplify things tremendously. But just reviewing the literature, there is such a huge dichotomy of what people believe about this topic. I think that would be very difficult to do at this point.
Yeah, the other thing is, I'll chime in, is I do find it interesting that all of our work's always been on carbon monoxide, but post-anoxic leukoencephalopathy is a problem that has plagued a whole variety of different conditions. I just think for us, CO creates the right conditions to do it. So I don't know the literature that well from neurology, but it might be interesting to see if they do anything specific for their patients. I know a lot of people would do things like, cytochrome Q and all that kind of voodoo, but it's a fascinating topic that during my practice we will not have the answer to.
Let me throw a question out then. Some of the toxicology societies, including ACMT, have come up with guidelines on this and that, where the practice is quite murky, whether it be GI decontamination or other aspects of treatment. And given all the lingering questions and the fact that we really don't have much better idea now than we did 20 years ago about the use of hyperbarics, is there a role to try to develop some sort of consensus guideline? Would that be of help to toxicology practice or medical practice in general, or not?
I think a lot of centers might be plagued by the problem of availability.
Yeah, I think that's part of the problem that the ACEP statement had, is that, that you don't have a universal availability of the drug or the treatment at every ER.
And Eric Lavonis and other folks kind of did something similar to what you're talking about, Paul, in their 2008 Annals of EM, the clinical policy. It wasn't that we as a society agree on this kind of thing, but it highlighted a lot of the issues. And I think their goal was, in part, to highlight all this so that people wouldn't be held accountable when they said, I don't think there's a good reason to dive this patient. But I think you'd be hard-pressed to find that all of us will agree. At least in my experience, if you have an HBO chamber, you believe in it, and if you don't, you don't.
Any more last comments? It's about time. Okay, thank you so much to everyone for participating, and have a great rest of your day.